Hello, I had the pleasure of presenting this at CRT 2023, and I would like to represent this lecture to the rest of the online audience. Thank you very much, and we're going to talk about the over 50 shades of MAC management options. Now, there have been other sessions in this CRT mitral valve replacement session that talk about LVOT management, so I'm not going to go into details of that. What I will talk about is some of the management options specifically, and I'll share with you some cases that illustrates various features of MAC and possible treatment options. Here are my disclosures. So we know that there are over 50 shades of MAC, and of course, with each MAC being different in severity and anatomic distribution, the treatment option can be different. Here you can see that the severe mitral valve dysfunction related to MAC, you have to determine if the patient is symptomatic. If not, certainly you can just manage them medically. However, if they have persistent symptoms, they require medical therapy, you really have to refer them to a highly experienced mitral valve center in terms of anatomic evaluation and imaging workup, and then finally have a multidisciplinary heart team discussion. And you can see that here in terms of the management strategy, certainly if there's surgical candidates, you can consider surgical mitral valve repair. If they're not repairable, you consider conventional replacement. However, if they're not surgical candidate, then your real option is either transcatheter edge repair, medical management, or native TMVR or transcatheter mitral valve replacement. However, if there is also a hybrid option in terms of a direct implantation of balloon expandable transcatheter valve in patients who are surgical candidates, but the MAC is too severe for conventional replacement. So some of the challenges of mitral valve interventions in MAC is that the etiology is highly heterogeneous. There's mitral stenosis, mitral regurgitation, or mixed disease. There's small or eccentric conformable annulus, so it affects the device performance. The protruding calcium or thickened calcified leaflets can impact on TEER eligibility in terms of repair. Small LVOT cavity can impact on new LVOT obstruction. And finally, potential interference of the MAC with the TMVR device, so it affects device fixation, anchor, deformation, geometry, and even paravalvular leak. So you can see that in terms of the MAC with mitral disease, it really depends on is it predominantly mitral stenosis or regurgitation. If it's stenosis, then the really options are replacement. So you can do it surgically, you can do it direct valve in MAC or TMVR. If you have related regurgitation primarily, then you can certainly repair the valve surgically. You can replace the valve certainly. You can even do transcatheter edge repair. And if anatomically suitable, you can also consider TMVR. So in terms of screening, it's very important. First, you do transparacic echo for pre-op assessment. You can look at the quantification of MS and MR, but also look at the neo LVOT by just doing a quick eyeball test on certain views. TEs obviously is important in looking at the anatomy, but also procedural guidance. CT has been a gold standard in terms of pre-op assessment and anatomic analysis. And finally, fluoroscopic guidance can also be helpful in terms of device steering and also landmarking the MAC in terms of landing zone. You can see here's the example of the echo looking at the MAC. You can see this particular patient. You do a typical bicomissural X-plane. You can see it here. You can see also a 3D on-false view with MR quantification. CT, of course, is the gold standard. You look at the annual dimensions, but also how the MAC is distributed. Is it circumferential, horseshoe, or partial? What's the aortomitral angle? How the virtual valve sit in the landing zone? How wide is the MAC and how tall is the MAC in terms of sealing and anchoring? And of course, if you have patients who have only partial MAC, you likely will not be able to do a balloon expandable valve. So you have to consider the surgical repair, replacement, or TMVR. And you can see that here, if you have patients who are inoperable, clearly only transcatheter will be the only option. And then the hybrid TMVR depends on the LVOT obstruction risk and also the calcification distribution. In terms of surgical repair, you can see that with adequate leaflet tissue, if the MAC is less severe, you can just do an oversized annuloplasty. However, if it's more severe, you cannot place any annuloplasty sutures. You might have to do a partial band because remember, the MAC itself is kind of like a rigid annuloplasty at the inside the mitral annulus. However, you have inadequate leaflet tissue, If you don't have much MAC, then you could potentially debride that and then do a patch augmentation to improve leaflet coaptation. However, if it's more severe, you really have to remove the entire block of MAC to restore the compliance of the tissue for the surgical repair. Now, transcatheter edge repair can also be done. It really depends on anatomic and technical considerations. So first is mitral valve area and baseline gradient. Is the leaflet involved in terms of length and mobility? Whether there's presence of calcium, and whether you can safely grasp without detachment. Subannular calcium protrusion is a problem because it can interfere with the device, affect your grasping ability. And you have to really set expectations in terms of your MR reduction, given you likely may risk functional mitral stenosis. And also remember, you have to be very, very careful about your grasping to avoid SLDA. So let me show you a case. Here's a 74-year-old female with prior mitral valve repair with MAC. Certainly prohibitive surgical risk. You can see that here. And I'll show you the TEE. You can see that the P2 is completely frozen along with the MAC and the partial annuloplasty band. And you can see that there's a residual M out there after the repair. So what we decided to do is to place a clip, and a smaller clip, an NT, on the medial side of that frozen leaflet, because obviously where the leaflet is frozen, you really cannot grasp and bring the coaptation down. And you can see that here, that just medial to that frozen P2, there's sufficient leaflet to put an NT clip there. We typically use a smaller clip in terms of worry about the gradient. You can see that there was nice gripper bounce. We closed the clip. Really, the MR has significantly reduced. We're actually quite pleasantly surprised by that. You can see that here. The V wave reduced down from 35 to 22. The gradient went up to 5, which is acceptable. And the pulmonary vein flow actually normalized completely. So this is certainly a very good result in this context. And you can see that here is the final TEE. You can see this is fluoroscopic guidance. You really have to make sure you use fluoroscopy to help you to avoid parallax of the clip during the implantation, to avoid twisting the valve and causing more MR. And also be careful about where the MAC is and where also the native anatomy is. You can see that here very nicely. You can see the post-op echo. The clip remains very stable with mild MR. Certainly very acceptable for this kind of palliative option for this patient. So in summary, I think TEER in MAC really depends on your MAC severity and your leaflet morphology, mobility, and length. You can see that as a previous case where the calcium is located, how big the mitral orifice is, and what the baseline gradient. What we recommend is to slowly advance the clip close with a posterior guide torque up initially for grasping and then reopening it. But also when you close, make sure you give back tension to avoid tension on the leaflets themselves in order to achieve the optimal result and also minimize the risk of SLDA. Now, in terms of replacement from the surgical standpoint, if you have partial or non-circumferential MAC, you can certainly just do a conventional replacement. However, if it's horseshoe or severe, you may consider a hybrid approach with a balloon expandable valve. And you can see that here, these are the steps on assessing the anatomic feasibility in terms of different approaches. And I'll just show you a quick case here. This is a hybrid TMVR and MAC case. You can see we resect the anterior leaflet with debride some of the calcium to improve the landing zone. You can see we actually sew in a felt strip that reduces the risk of paravalvular leak and will cushion against the MAC to avoid AV groove disruption. And just in the interest of time, I'll fast forward this. Essentially, we create a new cuff, and in fact, you don't have to oversize so much. You can actually sew 2 layers of felt strip here to increase the bulk and the sealing if you worry about the valve is being undersized. And we have done that before, as long as you inflate the valve optimally, and you can place some sutures from the atrial side to help anchor the valve, you will unlikely need to risk atrial migration. We do balloon the annulus here. You can see that with the same size balloon to prepare the landing zone to circularize, and you can see this is the valve implantation now. We use a certitude system with 2 operators, one guiding the position and one slowly inflate. And you can see this is the final result with no PVL and no MR. And certainly it really reduces the cross time and cardiopulmonary bypass time to improve the safety of this operation. However, there is still a risk of LVOT obstruction, particularly if you have a very thick septum. There's still a risk of paravalvular leak, device migration, embolization, and AV groove disruption. So there's still a learning curve associated with this procedure. We already talked about the various risk factors of LVOT obstruction. You can see that here, aortomitral angle being one of them, prominent septal hypertrophy, elongated mitral leaflet, and protrusion of the valve into the ventricle, and also short AP dimension because of the potential valve elongation and incomplete expansion. However, there are some issues predicting this on top of what we just talked about. Remember, all these modeling with CT are static. We just can't predict exactly how the valve will land at the very end. So for example, if you have anterior tilt, anterior annular displacement, or more ventricular deployment, you may end up obstructing the LVOT even though your measurements pre-op may be adequate. The final valve geometry is also unpredictable. The valve might elongate because it's inadequate foreshortening, and so this can potentially lead to LVOT obstruction in the mid-cavity as well. Then the real question is, what is the real cutoff to avoid significant gradients? Is it patient-specific, or is there a general range that we can apply to all the patients? And also, what is the highest tolerable LVOT gradient in a patient without causing hemodynamic collapse? We just don't have that answer right now. So let me show you another case with a TMVR MAC balloon expandable valve. So this is an 85-year-old with prohibitive surgical risk. You can see a normal EF, certainly risk LVOT obstruction is very high because of hyperdynamic. You can see a very, very nasty looking calcified mitral valve with a great high gradient, also a significant amount of MR as well. So you can see the CT here near the circumferential MAC, very large annulus. Here you can see the neo LVOT is actually rather small, 131. At the actual native LVOT would have been 440, so certainly very high risk of LVOT obstruction. If you look at the index neo LVOT, you can certainly see that it's almost approaching the point of severe aortic stenosis. If you think about it that way, aortal mitral angle is certainly also unfavorable, and the septal leaf thickness is very high. So certainly all the markers for LVOT obstruction. The patient was actually declined any intervention a number of years ago for readmitted heart failure, and so we really feel that we don't have a luxury of doing an alcohol septal ablation and wait 4 to 6 weeks and then proceed with the treatment. So we actually attempted to do an acute concomitant alcohol septal ablation. Here you can see that we really obliterated that septal, as you can see the blue circle, and we decided to use a true flow balloon placed in the LVOT in case we have to rescue for LVOT obstruction. We also have a cardiopulmonary bypass and impeller for support as well as a backup. So you can see this is now during the procedure. You can see the intraprocedural echo, moderate MR, severe MAP, and severe mitral stenosis. No LVOT grade in the baseline. We balloon the septum, place the sapien valve successfully. You can see the MAC, and you can see use that as a landing zone in addition to the echo. And you can see interestingly, despite all the risk factors, you can see the bit of a septal dyskinesis, and actually there was no LVOT gradient and actually no LVOT obstruction at all. There was just a peak gradient of 26, but the patient was completely asymptomatic. And you can see that actually the septum thickness that we measured was reduced, and you can see the valve has really fully expanded inside the MAC, and it has no risk of migration, especially if you have a little bit of a ventricular flare, as you can see that here. Now, TMVR, native TMVR in MAC has also been done. This is the first experience from Tendyne, and you can see that we're going to show you a case with a self-expanding valve with a 67-year-old female, mixed MS-MR with radiation heart disease, certainly calcified ascending aorta, certainly very high surgical risk. You can see the echo here, MAC, MR, really not a TEER candidate because of the gradient. You can see that we choose the Intrepid valve as part of the early feasibility study with the Intrepid and also part of the Apollo trial. And you can see this is more like a partial MAC, so certainly a balloon expandable valve would not be feasible, but also the annular perimeter and the sizing just way too big for any balloon expandable valve done in an off-label manner. So we decided to do that with the Intrepid, and you can see the valve AP dimension is 28 millimeter, just about the threshold of the anatomic feasibility. However, you can see the neo LVOT went from 118 to 168 across the multi-phase evaluation, which is important for every single patient. And certainly this is a high risk of LVOT obstruction because you can see that here, the valve can potentially be constrained, can elongate, and also the neo LVOT is actually quite small and systole. However, early systole and mid-systole appears quite favorable, so we were approved by this case to treat, and you can see the femoral vein assessment was also adequate for transvenous access. And so it was a femoral venous cut down. This is the picture of the valve deployment on echo and fluoro. And you can see where the MAC is located. This is an aerial view. And after the valve is implanted, there were actually a bit of a mild, moderate MR, central MR, because the valve, you can see, is quite elliptical. However, there was no LVOT obstruction at all. In fact, the gradient is actually only 7. You can see, however, the valve appears quite constrained, and at 6 months, there's only trivial central MR, so that's certainly improvement of the frame expansion. However, if you look at the initial implant, you can see the valve, even the inner valve, is quite elliptical. And on CT, you can see the inner diameter rather than 28, as we predicted, is only around 23 in the AP dimension. More importantly, if you look at the pre-op assessment and evaluation, you can see the valve protruded into the LVOT, thinking that the LVOT obstruction risk could be quite high. However, you can see that the actual final implant, you can see the new LVOT is actually much more generous, and you can see that much larger than predicted. However, one thing that we have not accounted for is the valve elongation because the AP compression, and you can see that here by looking at this modeling. You draw a line across, you can see that both annular plane, the valve actually has elongated more in the ventricular manner, almost to the mid-septum. So certainly in patients who have a more prominent mid-septum and also a smaller LV cavity, this can also potentially obstruct. And of course, if you have an anterior tilt, anterior displacement of this device, it can also lead to obstruction. We just don't have an answer of how to model this preoperatively. So I think in summary, the echo and CT are key to evaluate patient treatment options in MAC. In surgical patient, you can depend on MAC severity, leaflet involvement, and annular size. You can consider surgical repair or conventional hybrid MVR. TEER is feasible in a subset of patients, but may risk SLDA. Percutaneous TMVR, certainly the eligibility is limited by anatomy, ability to anchor and sizing, but also LVOT obstruction risk. Adjunctive techniques such as septal ablation, lampoon, and others may improve candidacy. And of course, we really need to improve our technology design to adequately address this sick population with high midterm mortality, as some of our data have shown. So on that note, I'd like to thank you very much for your attention.